Good evening and welcome you all to this instruction course on primary angle closure disease. I am the chief instructor and these are all my eminent co-instructors. Dr. Ronnie George, who is the director of the glaucoma services, Shankar Nethralaya, Chennai. Dr. Manju Arpillai, who is associated with the glaucoma services at Arvind Eye Hospital, Madurai for the past 24 years. Dr. Ganesh Raman, who is the Chief of Glaucoma Services at Arvind Eye Hospital, Coimbatore, and Dr. Shweta K., who is working as a glaucoma and phacosurgeon at Jyotis Eye Care, Kannur. All of them will be enlightening you on what you really need to know on primary angle closure disease. And coming to my topic, which is on nomenclature-related controversies, a good established classification and nomenclature system is essential to understand the disease with respect to its pathogenesis and chalk out a strategy for treatment. All of us know that primary angle closure disease is not a single entity, but rather it has varied clinical presentations about which Dr. Manju will be enlightening you in this session. And there do exist some confusions in gonioscopy and mechanisms of primary angle closure glaucoma. So encompassing all this into an established nomenclature is what is lacking in the system now. There are various ways of classification of primary angle closure glaucoma. These are all depicted on the slide. But what we need to understand is that we still need to have a comprehensive, well-accepted system on primary angle for clinical as well as research purposes. Coming to the clinical classification, which is based on the onset and timing of intraocular pressure rise, it is classified into acute and chronic. And the acute, based on the signs and symptoms, can be classified into preclinical with the prodromal acute attack, which could be presenting as mild variety, or an acute sudden attack, and both of it can have preceding intermittent stage, and if not interfered with medically or self-aborts, or if it doesn't abort by self, it goes into the next stage, that's the chronic stage. Unlike the primary open angle glaucoma, where you have a triad of raised intraocular pressure, cup disc, and field defects, PACG does not require glaucomatous optic neuropathy damage in its definition. An angle is essentially normal. In chronic PACG, the peripheral anterior synechiae is almost always present. But one should understand again that the fallacy is that a subset of chronic angle closure can exist without peripheral anterior synechiae, and similarly, in acute angle closure glaucoma also, you can have cases with PAS. So again, there are a lot of terminologies, some where you have ocular hypertension with narrow angles and angle closures with previous angle closure attack. You don't know where to put them in the terminologies. Gonioscopy is very important for the diagnosis of angle closure glaucoma. And again, there are confounders in the grading system because Schaffer looks into the angle width and grades it from 10, 20, 30, 40, 45 degrees. And the Shees classifies based on the extent of the anatomical landmark seen. So all of them are concentrating on one aspect, and actually the spectrum is so complex that it is difficult to assess and define the glaucoma status with just one characteristic alone. So Spaeth looks into the angle width as well as looks into the plane of the peripheral iris configuration and looks into the level at which the root of iris inserts. So it's probably better. So thereby we classify into open or closed angles, occludable angles, and in the occludable angles whether they have potential for closure, which is revealed by either indentation or manipulative gonioscopy. The epidemiological classification, put forward by the International Society for Geographical and Epidemiological Ophthalmology, is actually very popular, and it categorizes into three groups: the primary angle closure suspect, wherein you have a normal disc and field, but occludable angles, while the primary angle closure has peripheral anterior synechiae, and primary angle closure glaucoma has both disc and correlating with field defects. Here again, the issues are, what is the definition of occludability? If you take more than 270 degrees of the posterior pigmented trabecular meshwork not seen, it's a very stringent criteria, and you miss 50% of those who have either PAS or GON. And if you take 180 degrees not seen, then again, though the threshold is very liberal, here again you may miss those with focal PAS or minimal appositional closure. Then the diagnostic criteria for GON in the ISGEO classification, again, it looks into the 97.5 percentile of normal population, which means a CDR of 0.7. So many in this definition will not be classified into PACG, even if they are glaucomatous. Look into this case scenario when you have diagnosis of a primary angle closure, that is no GON and elevated IOP. When you have elevated IOP, that indicates trabecular meshwork obstruction. And the limitation of this classification is it doesn't take into account the grade of trabecular damage or optic nerve head damage, or does not address ocular hypertension. So this subset requires a more closer follow-up because of the high risk of conversion to PACG. Next, again, you can have narrow angles without PAS, and that means they have raised IOP, they have GON, but the mechanism, it has components of both open angle and closed angle, and that belongs to the combined mechanism group, which again is not reflected in this classification. So if you combine the clinical stages with the ISGEO classification, if you look into the third row, you encompasses PAC with the ocular hypertensives. It is forms a separate category on its own. Coming to the mechanisms which look into the mechanism behind primary angle closure glaucoma, there I would like to say is that whether it is feasible to combine the mechanism also into the classification, clinically combine the two, it is to be thought of. But you have to, this particular classification actually, if you see any of the factors pertaining to the lens or plateau iris or ciliary block or aqueous misdirection or appositional synechial closures looking at the level of trabecular meshwork block, it is better to define it and classify it as pupillary block glaucoma, plateau iris syndrome, malignant glaucoma, creeping angle closure or multi-mechanism, because by this you explain the 58% patients who after laser iridotomy do again have recurrent acute attacks. Some of the case scenarios in daily practice wherein, which highlight some of the controversies is, all of us see patients with raised IOP and occludable angles and synechial closure and a seemingly normal disc. According to the ISGEO protocol, you would call it as a PAC. But if you investigate and you see that the individual has OCT clock hour thinning, as well as a normal field, the diagnosis shifts and gets reframed to an early stage of PACG. So to diagnose PACG with the requirement of glaucomatous optic neuropathy alone is controversial. Coming to the second scenario where you can have acute angle closure attack, which is a straightforward diagnosis because all you want to have is this very sudden rise in IOP, but you can have instances when the patient may be having an intermittent closure and goes into an acute attack, or you can have a chronic angle closure patient who has a supervening acute attack. Where do you put these groups of patients? You may have an angle closure glaucoma suspect patient with a previous attack as reflected by this glaucom flecken. So these are the lacunae in the existing system. Coming to the third scenario, when you have a severe acute attack, you can have a disc edema. So not only GON matters, even other vascular factors need to be looked into, and that is not there in the definition of the ISGEO system. So this OCTA is a sensitive tool which looks into the peripapillary vessel density. As you can see on the left-hand side, the figure A shows normal. In comparison, the angle closure post 1 month post-acute episode, look at the reduced peripapillary vessel density and the flow index as well is to reduce. While in the POAG on the right-hand side, you can see a focal loss here of the peripapillary vessel density. So these are all I would like to speak on. And next I invite Dr. Shweta for her talk on diagnostics aiding the diagnosis of PACG.
Good evening. Thank you, Dr. Meena ma'am, for this opportunity. I'll straight away go into my topic, that is diagnostics aiding PACG diagnosis and overview. The most important, what we have is first and foremost is slit lamp examination, gonioscopy, ultrasound biomicroscopy, anterior segment OCT, and the biometry. So the diagnosis starts from at the level of the optometrist. You can all train your optometrist to see the torchlight examination so that we do not miss any cases. So any case of doubt, they can send directly to you. So you can grade it according to the torchlight examination as grade 1, 2, 3, and 4 as shown. Then we have the Van Harris technique, which is a slit lamp examination. It is also known as a limbal anterior chamber depth measurement, where it is graded based on the anterior chamber depth is compared with the corneal section, and grade 4 is more than or equal to 1, and grade 3 1/4 to half, and grade 2 equal to 1/4, and grade 1 less than 1/4. So grade 1 is one which we can have the occludable angle. The most important test that we have is a gonioscopy. This is still the current gold standard method for detecting the angle closure disease. Especially it has to be done under dark room, the dynamic gonioscopy. So here you can see the real-time image of a gonioscope, an open angle, where you can see the Schwalbe's line, non-pigmented trabecular meshwork, pigmented trabecular meshwork, scleral spur, and the ciliary body band in the right side. So the technique of gonioscopy is really important, because you have to make sure that the light doesn't fall onto the pupil, and you constrict the pupil, and that can also always cause a false opening of the angle. So whenever you see the superior and inferior angle, keep the slit height at minimum, and you can increase the width so that you see just that angle. So, and whenever in doubt, you can use the corneal wedge technique. And if when going to the lateral angles, that is nasal and the temporal angles, you have to keep the slit at a minimum width, and you have to increase the height of the slit. The main thing is you should not allow the light to fall on the pupil and allow the false opening of the angle. Next is the corneal wedge technique. Corneal wedge technique is for the detection of the Schwalbe's line. You have the anterior and posterior, light reflects from the anterior and posterior surface of the cornea. It comes and joined together at the Schwalbe's line. So you can identify the Schwalbe's line, and the rest of the angle is easily identified. Then whenever you are not able to see the angle, you can also do the manipulative gonioscopy. What it means is, when you're seeing the angle like this, and you can ask the patient to look towards the mirror, whichever mirror you are examining looks towards it, and you can see that angle is opening. So this is an oppositional one. And always be careful to distinguish between the peripheral anterior synechiae and the iris process. And this is a broad-based peripheral anterior synechiae, and you can see the narrow angle. And also 4-mirror gonioscopy is the one which used for the indentation gonioscopy, but it is little difficult to master. But once you master it, you can just you can see the ostium, trabeculectomy ostium in the superior angle. And this one video is from the glaucoma.org, where you can see that once it is pressed, you can see the angles opening up. So we have to differentiate between the synechial angle closure and the appositional angle closure. But the limitation of gonioscopy is you need a skilled examiner. There can be high inter-observer variability and not able to track progression, and it is highly subjective. And we are not able to see behind the iris. For that, the ultrasound biomicroscopy had come, where there is a high resolution in imaging of ocular structures up to the pars plana region. So principle is similar to B-scan. B-scan uses 10 megahertz, whereas UBM uses 50 megahertz. More the frequency, lesser the penetration, and better is the resolution. We can have qualitative as well as quantitative assessment. There are different scans in UBM. You can have a transverse scan. You can have the longitudinal scan, which has a radial image to the single clock cover, and you can have the axial scan according to the where you keep the mark. I'm not going into detail of the examinations. And probes you can have with the cup, where we can fill it in water and keep it in the patient's eye, or directly you can see the clear scan device, where you can directly keep it into the patient's anesthetized cornea. So the most important landmark what we have to identify is the scleral spur. So this is an example of an angle closure, where you can see the pupillary block and the angles are closed. And this is an example of a plateau iris, where you can see the anterior rotation of the ciliary body and the double hum sign of the iris. And even the iris, whatever behind the iris cyst, these can be diagnosed only with the ultrasound biomicroscopy. But limitation is, it is a contact method. We need an experienced, skilled person, and repeatability is an issue, and it is time consuming. Then comes the anterior segment OCT, which has so many advancements recently. Initially, it started with the time domain OCT, which had 1300 nanometer light, which had good depth of penetration, but the resolution was not good. Then came the spectral domain OCT, where the resolution was good, but the depth of penetration was less. And now we have the swept source OCT, which uses 1300 nanometer of light, and it gives us good resolution as well as the depth. So these are few of the examples of time domain and spectral domain OCTs. The OCT is non-contact, and it can minimize the test-induced distortion of angle, and it can be performed by technician, and it has a faster imaging speed and more reliable detection of the key landmark. But it is difficult to identify the anterior synechia and the neovascularization, and it cannot differentiate appositional and synechal angle closure. Here, the important landmark what we have to identify is the scleral spur. Scleral spur is a junction between the inner corneal surface and the sclera. So this is the landmark. From the once it is identified, rest of the measurements are taken directly by the machine itself. So this is an anterior image showing the scleral spur. And it can also, the segmentation also has to be confirmed in anterion, and you have various parameters. Among this, the most important is the lens fold. Well, lens fold do have an important mechanism in angle closure. And it's not just the apposition of the iris and the trabeculum, Ashok, what we are interested in. We have to see the iris thickness also. The increase in the peripheral role of the iris in the periphery is also gives more chance of getting an angle closure. So look for pupillary block, plateau iris configuration, thick peripheral role of iris, and exaggerated lens vault. So some of the differences of UVM and OCT, I'm not going into detail. So mainly we have static factors like lens vault, anterior chamber area and volume, and iris thickness and area, and dynamic factors, changes in iris area in response to the pupillary. And there is something called an ITC index, which is there in the swept source OCT, where they take all 360 degree of the angle is measured, and it can show us where the iridotrabecular contact is present. The most previous OCTs it was not present, only in the swept source OCT it is there. So you can see that that blue, whatever is represented here in the lower image is ITC, iridotrabecular contact. So also we can also use a biometry. The importance of biometry is you can see the anterior chamber depth. It is said that if you have an anterior chamber depth which is less than 2.4 millimeter, there is more chance of getting an angle closure there. And provocative tests, we know that we do not use these nowadays, like darkroom prawn positioning and pre and post dilatation. Generally we do not do it. So it's all matters is we all have to see it as a patient together, right from the history taking, and gonioscopy is very important. Even if you feel that the anterior chamber is not that shallow, you have to do the gonioscopy, because that can be an angle closure too. And I thank my mentor, Dr. P. Satyan sir, for helping me out with this. Thank you.
For the excellent talk. You have covered all the investigations, and I think, like you mentioned, the gold standard continues to remain gonioscopy. And it has got a long learning curve. One should, even as consultants, I think we keep on improvising on our findings with each time as we see more and more cases. So I invite the next speaker. I invite Dr. Manju Pillai for her presentation on challenging angle closure disease presentations.
So, good evening, everyone. So, I have outlined my talk as basics of an angle closure and primary disease, secondary disease spectrum, and some clinical scenarios with some case presentations. So, why should we bother about an angle closure? Because POAG is more than PACG, and PACG happens in 25% of all glaucoma worldwide, but blindness from PACG is 50%. So, the risk for blindness is 3 times more with PACG than POAG. So why is it difficult to pick up angle closure? Is because in a lighted room, the angles are open, and in a dim light, the pupils dilate, the angle crowding occurs. So there is an article on primary angle closure or glaucoma on what we know and what we don't know. So there is some part of genetics that is involved, and there is a small cornea, shallow AC and short axial length, and small anterior chamber with greater iris curve and a larger iris volume. There could be an anatomical crowding, thicker peripheral iris, plateau iris, and anteriorly rotated ciliary processes, big lens wall, thick lens, and anterior lens position. And according to the age, living habit, mood, weather, and others, they can have a narrow ankles, which can lead on later to an angle closure glaucoma. Uveal expansion can also close a pupillary block or a non-pupillary block. And I suggest American Academy of Ophthalmology Preferred Practice pattern, where Shweta has described about ITC. So in PAC, more than 180 degree ITC is present, the other two are absent. In primary angle closure, more than 180 degree ITC and elevated IOP or PAS is present, and primary angle closure glaucoma, even disc changes are present. So in the disease progression, angle closure glaucoma, if the laser PA is a treatment in 22%, in 5 years' time, they develop to primary angle closure. In 28% or 28.5% in 5 years, they change to angle closure glaucoma. So we need to do periodically gonioscopy in all these suspects to make sure they have not progressed to angle closure and angle closure glaucoma. So in the laser peripheral iridotomy in primary angle closure, most PACS won't require further treatment. PAC, acute primary angle closure, and PACG eyes require further treatment to lower IOP. So why is PA not curative in all patients? If there is a pupillary block, if there is a plateau iris configuration, if there is a peripheral iris crowding, or if there is a high lens vault. So rich anatomic levels of angle closure, which Meena has described, the levels are iris and pupil, it can cause a pupillary block. At the ciliary body level, it's due to plateau iris. In the lens, it's due to phacomorphic glaucoma, and retrorental, it's malignant glaucoma. In East Asia, mixed mechanism angle closure is believed to be especially prevalent. WGA consensus for a prime prophylactic laser iridotomy is APAC, that's acute primary angle closure, and its fellow eye with PAC or PACG. Those who require a frequent pupillary dilatation, inadequate medical access, and symptomatic PACS. There are some clinical scenarios that I would like to explain to you. That is with pupillary block, that is in sequential pupillae, phacomorphic, aphakic or pseudophakic, and silicone oil induced. Without pupillary block, if there is an anterior pulling mechanism or a posterior pushing mechanism. So in a pre and post PI, this case is an iris Bombay due to uveitis post cataract surgery. It was relieved by a laser PI. Note that the laser PI was patent and deep anterior chamber is there after a PI. Pupillary block by fibrin membrane, that is post-operative day 50 after an uneventful SICS. All shallow AC post cataract surgery is not malignant glaucoma. You can see the deep PC in this eye. And UBM helps in picking up the cause, and fibrin membrane is covering the pupillary margin. So you can do a YAC PI, and if it's not getting resolved, you can even do a fibrin membrane lysis, and after 3 days, AC deepens centrally and intense steroids, and after 3 days, AC deepens well, and PI is small, but it's patent. Sometimes PI may not be curative in cases like this, where there is a 360-degree synechia with flat AC as in a chronic uveitis, where we have to go in for alternative surgical procedures, mostly a surgical PA trabeculectomy, or after a B scan, once a uveitis settled down, we have to go in for a GDD. In lens-induced angle closure glaucoma, when there is ischemic cornea with intumescent cataract and high intraocular pressure, we have to always look for the other eye angles also, and the lens removal is the only treatment. Microspherophakia and secondary angle closure, you should note that there is a weak and abnormally elongated zonules in the microspherophakia. These enlarge anterior lens movement, leading to recurrent attacks of secondary angle closure, and we have to remove this cataract. And young male with high myopia presented acutely with high IOP and shallow AC, you note that there is a small lens in the UBM. There is another one entity that we come across, that is nanophthalmos. Post cataract surgery in both eyes, AC even looks shallow even after a cataract surgery, and you can see an iris chafing because of the difficulty that we had in placing the lens. And this is the axial length to show that it was a clear-cut case of nanophthalmos. In pseudophakic glaucomas, IOL position can cause an angle closure. that is IOL in the sulcus with a secondary angle closure. The case like scenario was recurrent hyphema after phaco. UBM clinched the diagnosis that the patient had recurrent hyphema is because the single piece lens was placed in the sulcus. You should never put a single piece foldable IOL in the sulcus. So one haptic in the sulcus and UBM helped in picking up the cause. Another one entity that we come across all the time is a silicone oil induced pupillary block. You can see that the PC is very deep and iris will be steepened like this and it will have a bend and silicone oil would have filled the whole anterior chamber. The removal of the silicone oil bubble after PI and the silicone oil bubble gets relieved to the posterior chamber, pupillary block is relieved and the bubble gets retracted. There are some cases where you don't have to do ACPI and one is the ICE syndrome where anatomy of the angle structures are like this but clinical picture shows an entity that it's an ICE syndrome. And the neovascular glaucoma where you can look very carefully. If there is a florid NVI, then you don't have to do a ACPI. You have to do alternate treatment along with Avastin or any other retinal pathology. And due to some other changed lenses or any other anterior chamber lens or something else, if they do somewhere outside and bring it, they get a malignant glaucoma that is IOP is 34, corneal edema, flat AC and a patent iris. So 3 days after atropine, the IOP goes down to 12, clear cornea, AC is deep, and the fundus shows a decompression retinopathy. The trigger was an intraop hypertonic. So you should see that the entire lens is shifted up. If the IOAC is not coming down with all these steroids and atropine, then we have to go ahead with a vitrectomy in these type of cases. So conclusion is angle closure is a puzzle that has to be solved meticulously using all the available investigative modalities, not only gonioscopy. Only combined mechanisms of angle closure can happen often and treatment can vary from LPI to complex glaucoma drainage device implants. Thank you.
Thank you, madam, for that excellent presentation on challenging cases. Now I call upon Dr. Ronnie George, sir, for speaking on surgery in angle closure disease, when to do and which one, trabeculectomy versus combined phacotrabeculectomy.
Good evening and thank you, Dr. Meena, for making me part of this IC. So when we look at angle closure disease, these are all the various ways they're present. You can have all the types that were mentioned earlier and also the acute primary angle closure, and you can have plato-iris in any of these coexisting with any of these conditions. So I'm going to discuss what the available evidence is in each stage of angle closure and the risks and benefits potentially in different stages. So when you look at the progression of primary angle closure suspects, and this has already been presented, 22% progressed over 5 years, and in the Mongolia study by Paul Foster, 20% progressed at 5 years. The risk of progression to PAC from PACS is low, and which is why we don't recommend anything except in high-risk cases. And therefore, for PACS who has undergone YAG LPI and on follow-up and has developed cataract, if the angle opened up post-LPI, you can do cataract surgery whenever you do it routinely. If the angle did not open up post-YAG PI, do it a little earlier because that will help with the angle. In somebody who's an angle closure suspect without a YAG PI in place, maybe earlier cataract extraction could be considered. But keep in mind that there should be a cataract. Coming to the glaucomas now, when you look at the primary phacoemulsification and IOL implantation for acute angle closure glaucoma, this was a terminology at that time, but this is today called acute primary angle closure. There was this non-randomized comparative trial which looked at lens extraction versus surgical iridectomy as a treatment, primary treatment for this. And what they found was the phaco group required fewer medications, 0.1 versus 0.45 between the groups. But in both groups, you had patients requiring between 0 to 2 medications at the final follow-up. Additional surgery was necessary in 5 eyes in the phaco group and in 20 eyes in the iridectomy group. But once you reanalyze this by excluding the patients who required only cataract surgery in the iridectomy group, there was no difference between the two groups. So we know that post-acute angle closure cataract does progress a little bit more rapidly. And what was also interesting here was that 7% of these eyes had a capsular tear or vitreous hemorrhage, vitreous loss. This wasn't a large case series, so fortunately there was no expulsive hemorrhage or something like that. So in these hot eyes, going and unnecessarily removing a cataract is not a great idea, but typically with an acute angle closure, which is resolved post laser iridectomy, you probably don't need to do anything very aggressive. But what if you have medically uncontrolled PSCG? So there is this, there are two papers which have compared trabeculectomy in medically uncontrolled chronic angle closure glaucoma with cataracts versus phaco alone. And these are eyes which had at least 180 degrees of cynical closure. So you can see the IOPs were about 24. They were on more than 3 drugs each. They had close to 270 degrees of cynical closure. They had fairly significant visual field damage, minus 17 and minus 18 decibels. And about 1/4 of the eyes in both groups had a history of acute primary angle closure. So when you look at the intraocular pressure, definitely IOP levels were better in the phacotrabeculectomy group. The number of drugs required post-op was also better in the phacotrabeculectomy group. Over time, within these two groups, in the phaco group, 4 patients out of the 25, which is again about 15 to 20%, required trabeculectomy, while in the combined phaco-trab group, no patients required additional medications at 12 months after surgery. So in patients with chronic angle closure or primary angle closure glaucoma with uncontrolled IOP, phacotrabeculectomy seemed to do better than phaco alone. What about if you had medically controlled PSCG? So you have medically controlled PSCG. What about trab versus phacotrab? And this is again with 180 degrees of cynical closure, very similar results. So here you have 3 groups. The top is the medical group who had only phaco. The bottom is the phaco-trab group, and the middle is the phaco-trab group with the hypotony cases removed. So they had 7 patients in this group who had hypotony. The number of drugs required post-op was again lower in the phaco-trab group. So in the phaco alone group, 14% progressed at 2 years. In the combined phaco-trab group, 16% progressed at 2 years. So there were really no differences in progression between the two groups. But keep in mind that when you did a phaco-trab, in these patients who were controlled medically, you landed up with significant hypotony. 7 out of 35, which is in 20% of people. So patients medically controlled with PSCG, you're probably better off just doing the cataract alone. Now, primary angle closure to primary angle closure glaucoma, this slide has also been shared before, about 28% progress over 5 years. And we say that all eyes with PSC should undergo a LPI. So here again, you have 2 situations. You have PSCS with PSC or raised IOP, or you have PSCS without Syne-K but with raised IOP. They're all going to have a YAG-PI, that's protocol. And in that situation, you'll land up with a group which has narrow angles post-LPI, and you'll land up with a group which has open angles post-LPI. So if you have open angles post-LPI, there's really no rationale to go in and take out the lens. You can probably manage with a trabeculectomy alone. But if you have open angles post-LPI and uncontrolled intraocular pressure in this situation, you would consider doing a trab and a cataract surgery, because that is what seems to work even in PSCG. What if you're controlled with intraocular pressure on 2 drugs? So if you have open angles post-LPI, I would consider only cataract surgery. If you have narrow angles post-LPI, again I would consider only cataract surgery if they are controlled on 2 drugs. The exclusion to the rule is if you have extensive Syne-K with narrow angles post-LPI, in that case I might consider adding on a trabeculectomy, because these eyes you can sometimes cause the angle to decompensate after surgery, especially if you're on more than 2 drugs. So keep in mind, when you're on more than 2 drugs, you follow the rules very, very similar to open angle glaucoma. You combine it with a trabeculectomy when you think it is necessary. What if you have PSCG with uncontrolled IOP and cataract post-LPI? I think the evidence is fairly clear that if you have open angles, definitely trab plus cataract surgery. And if you have PSCG with controlled IOP with 2 drugs and cataract post-LPI, only cataract surgery unless you have very advanced visual field damage. So when you're on more than 2 drugs with PSCG, what do you do? So I'm going PSCG and PSC. So this is PSCG now. In this situation, not controlled on 3 drugs, definite damage on the visual field, you definitely need to do combined surgery in both groups. There's really little role for you to do a cataract alone. Keep in mind that accommodation is an important function. So if you have an open angle and a controlled IOP post-op, and an uncontrolled IOP post-op, post-laser, you can probably just go ahead with only a trab in those eyes. And keep in mind also that cataract extraction is not without complications. It's higher with angle closure, and angle closure, an acute attack or an eye with a very high IOP, you're more likely to run into trouble on table. And not all apposition opens up after surgery. So just doing a cataract surgery, when you can still land up with residual apposition, and this is something that you should keep in mind, because even these patients require occasional gonioscopy. There are some exceptions to the rule. If there is a history of aqueous misdirection in the fellow eye, I would always prefer to combine with a cataract extraction, even if the cataract is very early, because becomes easier to manage these eyes. If the angles are open post-iridectomy, but you have a very convex iris, there's a high lens vault, there's very little buffer for the AC to shallow if you do a trab alone, so combine with a cataract surgery, even if your IOPs are okay. So to summarize, you have multiple situations. With PSCS, you have a lower threshold for cataract. With PSC, with residual angle closure post-PI and uncontrolled intraocular pressure, instead of doing a trab alone, combine with a cataract surgery. With PSC with open angles post-LPI, if your pressures are controlled, you can go ahead with a trab alone, but you have a lower threshold for a cataract. Acute primary angle closure, the best option is probably deferred cataract surgery. Consider doing a trab alone if you're struggling to control it. PSCG with residual angle closure post-PI and uncontrolled intraocular pressure, definitely combine your trab with a cataract surgery. And PSCG with open angles post-LPI and uncontrolled IOP, if you're on 2 drugs, do only a trab. If you're 2+ drugs, maybe a slightly lower threshold for cataract surgery. So thank you, and I hope that answers some of your questions. I haven't spoken about mix because he's going to talk about it, but in some of those situations it will be useful.
We'll have questions raised after the session. And now I invite Dr. Ganesh Raman to speak on MIGS mix in primary angle closure disease.
Thank you, Dr. Meena, and thank KSOS for providing me this opportunity. I'm going to speak to you on MIGS in primary angle closure disease. So MIGS, if you look at the advantages, there are numerous. You have spare the conjunctiva, it's ab in tono, sparing the sclera also, because ultimately if to do glaucoma surgery, you need significant amount of sclera. And then reduce surgical time. And the only demerits, some of them are that you cannot lower the IOP as good as trab. And of course, some of the MIGS do involve the conjunctiva, and then it again precludes other modalities of treatment. So issues with MIGS and angle closure is actually MIGS are actually indicated for open angle glaucoma. So if you are using it for angle closure, it's off-label use. If you use any device, for example, let's say iStent or a KDB, it's off-label by the manufacturer or the innovator or the developer. And then insurance also plays truants in that, so you don't get insurance approval for MIGS in angle closure. So if you write a diagnosis of PSCG and then MIGS, it comes boomerangs back on you. You don't get a sanction, okay? And most of the patients have to pay out of pocket. So MIGS, which are device-based like KDB, iStent, Hydras, they're quite expensive. So what we are left with in the Indian scenario is GAT, Tenito, and Bang. So this is some of our data. So the problem with MIGS again is that it's sometimes so good that patients don't come back to you. So look at the last column, and the post-operative IOP at 6 months is pretty good. So you have the last column is some of the patients haven't come back, but you still have good IOP at 3 months, 15, 16, 19, 16, 12, like that. So you get a good intraocular pressure reduction, and these are all off medications with very good visual acuity. And the diagnosis is all PSC or PSCG, and look at the cupping. So you have some of them 0.4, but many of them are 0.7 and above. So advanced, moderately advanced glaucoma. I'll come to this case. So this patient has bilateral angle closure glaucoma, 0.7 cupping, 0.5 cupping in the right and left eye. Presenting pressures were 36 on 3 to 4 medications, rheumatoid arthritis and SLE, and she has undergone multiple LPIs, and we couldn't do anything much for her in terms of trab, so we thought of mix. So finally what we did was, this is how she presented, past history of scleritis and healed now. So we went in and did all these are the options which were present to us, but we finally did a GAT with phaco for her. So having done that, we had very good response at 1 month, so immediately we did the other eye as well. So both the eyes underwent phaco-GAT, and this is how she presented at 1 month follow-up. And the intraocular pressure was 15 millimeters in the right eye, 13 millimeters in the left eye. This is at the end of almost 6 months. And the angles widely opened up. Even before that, the angles were pretty much opened up. So she was on 3 to 4 medication, but then we still went ahead and did a glaucoma mix procedure for her because we knew she's going to likely to progress. There's no assurance that she would not. And the main advantage was we were able to stop all the medications. So that's one saving grace in her situation. So conventionally, we usually address the nasal angle in mix. If you take any mix, for example, KDB or any mix, we address eye stent. Nasal angle also has more extensive collector channels. Whereas in this particular patient, we did an extensive GAT, that is an excisional goniotomy. We excised all the tissue or ripped open all the tissue because we were able to access the temporal region and helps to recruit temporal collector channels for aqueous humor, percolation, outflow. So if you were to do something like MIGS in angle closure disease, I would strongly recommend something like a GAT or a Tenito, which addresses both the nasal angle as well as the temporal angle for better percolation. So this is something which we have to think of. But any device-based procedure, you have to think of because they are expensive, you have to think of the insurance part, and they are not labeled applications for that. So coming to Tenitos microhood, so this is a device which addresses it has three devices actually. So in A you have the straight shaft, so it cuts the nasal angle about 2 clock hours superiorly and 2 clock hours inferiorly in the right and left eye. This is how it's represented. And then you have the angle device. So the angle device you approach supranasally on the right eye and the left eye, and one device which is right-handed will cut 2 clock hours to the temporal region, and the left will cut 2 clock hours to the infratemporal region. So what essentially you do is you have 120 degrees of cut here, and then you have 120 degrees of cut here. So instead of a 120 degree alone, you are able to open up the trabecular meshwork up to 240 degrees. 120 plus 120 makes it 240, so it's close to. So the only region which you leave out is, for example, if the right eye, this region, and the intranasal region. So you leave out about 120 degrees, but you open up most of the trabecular meshwork. So this is again a very cost-effective device. It's shortly going to be made available, and this is something which you could think of. So this is how the procedure works. This is the video courtesy of my friend and colleague Devendra Maheshwari. So after the phacoemulsification, and of course you should know intraoperative gonioscopy for this. So this is being approached from the temporal side to the nasal aspect, and then this this is the supranasal part. This is the supranasal part being approached infratemporally. So this is the angled device. Sorry. So you can see the trabecular meshwork. You can see that the iris has fallen back. If you have synechia, you could always do a mild goniosynecholysis and then see the trabecular meshwork. And once you incise, the trabecular meshwork gets excised, and you see the outer wall of the Schlemm's canal. If you have induced hypotony, you will have some bleeding from there. So it's always important that you do the lower part first and then you do the upper part. And this is the other device, which is the pair of that, and you incise the supratemporal part. So this is being approached from the again the procedure is being done. So if you don't have a good view, you can always reinflate the chamber and then proceed with it. So if you cut it in size correctly and you have induced hypotony, you will have a little bit of blood coming out from the trabecular meshwork. I don't know whether you have seen the... Yeah, so this is, I think this is being approached. No, this is also, yeah, this is again the same, just the straight incision one. So what you saw there was the angled one. This is from the temporal approach, so you address the nasal area. And of course, as you can see from the video, you can do it topically as well. So this is a straight angle device. And I think it's the same thing. I'll go to the next slide here. And certain complications you should always be aware of. This is of course a cannuloplasty, but you must know that a GAT and such procedures not very easy in angle closure conditions, mainly because can I have the video please? Is it playing? No? Okay, that's okay. So case selection is very important. So preferably always do a PI first because as I already mentioned, risk of malignant glaucoma is quite high and the EAGLE study can definitely be misleading. So don't go by that and treat your patients with just cataract alone. Mild to moderate glaucomas is where it is actually indicated. Advanced glaucomas, they don't respond so well. Do goniosynovial lysis if you find that there is extensive PAS. And it's very important to perform uneventful cataract surgery. So if you have vitreous in the AC or the lens is not placed in position properly, it's very, very difficult to do the procedure after that. So avoid excessive iris manipulation. You will have extensive pigment dispersion which will go again and block the outer wall of the Schnemm's canal and your collector channels will not percolate so well. Always deepen the chamber with sodium hyaluronate and flatten the iris against the PCIOL in the back. So anybody who has done MIGS, you will notice that the blood doesn't just come from the angle, it comes from behind the iris as well. Because as you introduce the suture or the incise the trabecular meshwork, you are inducing shearing stress. The stress gets transmitted to the ciliary processes at the back and they tend to bleed. It's also the iris root as well as blood from behind the iris. If you are doing a GAT procedure, leave sodium hyaluronate, 40% fill and anterior chamber, that's what we do regularly. But if you are doing a limited procedure like KDB, bang, Tanitos, we don't leave any OVD device in the anterior chamber. Be very careful of patients on anticoagulants or hypertension patients who are not under control, and be very careful of fluctuating BP. They may have taken tablets just before the visit. Once they go back, they'll stop the tablets, the BP will fluctuate, they'll report back with hyphema. And then you'll end up washing them in the in the OR again. We use very less steroid for our patients once we are done MIGS, whether it's any type of MIGS, whether it's eye stent or angle closure, we do GAT, KDB. We use only steroids only for 10 days. Rest of the month it's 3 times a day NSAIDs, preferably we use Nepafenac, and antibiotics 4 times a day, 15 days. And pilocarpine 2% for 10 days, 3 times a day. And if the intraocular pressure fluctuates, we repeat pilocarpine for 10 more days. And that's just about settles it because as you've seen the data which I showed you, KDB at the end of 3 months, they do pretty well. And we see them at 15 days, 45 days, and 3 months. So you could have some complications, especially in the early curve. You could have a cyclodialysis cleft. You can strip the DM. You can have hyphema, which requires AC wash, raised IOP. And you could always have blood behind the IOL, and then which will require early YAG capsulotomy. So ideal MIGS are patients who have MD of less than 15. And this is just an example to show you that a patient had blood behind the IOL, and then we had to do a early YAG capsulotomy within about 3 weeks' time. So I'll stop here. Thank you for a patient listening.
Thank you, Dr. Ganesh, for the excellent talk and the insight you gave us into MIGS, which I think we are very much in the dark, especially in the angle closure group of patients. Any questions from the crowd on any of the talks? Okay, so how routinely do you do the procedure as a combination procedure along with cataract surgery in angle closure patients? MIGS?
I think we offer it pretty fairly, regularly, especially if it's GAT and Tanitos. Now, since the devices are off-label, so we can only use the ones which are Tenito and the GAT. These are the two things which we offer. KDB was sort of reduced now. We used to offer it for, but the insurance was a barrier. So the cost goes very high for the patient with aspheric lens. So we do usually GAT as well as Tenitos. And for very low pay patients, we offer them a bang procedure.
I think in this high risk group patient with scleritis that you showed,
Yeah,
it's a big boon.
they
I
are
think.
pretty ideal for mix.
So you showed the patient with scleritis. She was on 4 drugs. Huh?
She was on 4 medications.
So if she did not have scleritis, would you still have done the mix or would you have done a trap?
Yeah, I think maybe we would have done a trap. Yeah, we couldn't really place mitomycin C or even cut the sclera there.
Because
Maybe we would have done a, the idea of having known all these surgeries is I can always come back to mix again. If I do a trap and it doesn't work, the advantage is I can come back and do a mix. So sometimes I think in that way also.
Yeah.
But I would definitely would have done something for her, not because of the 4 medications. I would have to do something for her to be off medications because that was.
So because like you said, most of the time you would do it on patients who are mild, moderate, controlled on 2 drugs. So when you're doing the cataract, you do this, you reduce the drop burden.
Yeah, so now since we know so many things and bang, Tenitos, we have access to it, we would just do a Tenitos and leave it, we would not, maybe I would not done a trap. If I can see the angle, I'll just cut open the angle and, allow percolation to occur and just do a mix first, even if she did not have scleritis.
Yeah, so
Yeah.
we tend not to do it when they are more difficult to control because typically if they're on 4 drugs, then sometimes you wonder whether the meshwork has collapsed and the Schlemm's canal has collapsed and therefore outflow has a
True.
problem.
If you look at her age, she is about, she's a little elderly. She's, I think, 62, 64.
Okay.
Yeah, so in that stage, 4 or 5 years of, medication-free life, that's quite helpful for her at that particular age. Putting drops at the age of 64, 65, it's easy, but after surgery, they would want to be free of all that as well.
Yeah, and Dr. Boni, regarding the patient's post-acute attack, you said always you prefer not to combine the combined procedure. So what amount of...
If it's in the acute stage.
Yeah, and if you're going to do the trap, then what is the... And definitely if medically the pressure is not controlled, will you do it immediately or maintain the patient on carbonic anhydrase inhibitors for some time and go ahead?
So if the pressure is like 50 or 60, you are not able to get them back, the attack is not breaking, or even after the attack is breaking, there's extensive synovial closure, the lens is reasonably clear, I'd make sure the topical steroids go in for a little while, and maybe within a week or 10 days, you take them up. See, this is a very, very small group of patients where you land up like that. Most of the acute attacks you can actually break. So this small group of patients, and you do a trap, they actually quieten down.
Recently, we came across a patient who has been on 3 drugs for a long time in the Gulf. And he, I think, used to have pressures in the range of close to 30s. But he didn't have much of a disc damage, and he was walking around happily till he landed up at one of the places in Kerala, and he was advised a laser iridotomy. So he was again apprehensive to do it in both eyes, so he did it in one eye. And post-procedure, unfortunately, he had a very high IOP rise, after which he had to be given mannitol and all that several times, and he was referred to us. And the decision to impress upon him to go through a trap also was very difficult. So here in this scenario, do you think the non-contact imaging devices give you any clue as to whether there could be suprachoroidal problems causing do you think there's a role of doing
Before pre-op?
Pre-op?
They don't, it's very difficult to predict. The downsides in this gentleman is he's got chronic angle closure. The angles, I'm not sure whether they've opened up after the laser iridotomy. And there's a whole amount of pigment and a very high IOP. So he has all the acute decompression risks. But most of the time, you would get away and see these are IOPs of 30 on 3 drugs. His whatever remaining meshwork is not working. So when you do the PI, especially if you've had to use a lot of energy, that pigment is gone and blocked the remaining meshwork and caused the spike. And because you don't have the luxury of waiting, you will have to go in. But sometimes you wait a little while, it settles down. It takes few weeks sometimes, but it settles down.
Okay, any questions?
One way of looking at this, if he is on 3 medications, you could always try initially, you could, turn around the medication, use pilocarpine for some time before you do the PI. So if he has 1 or 2 aquasuppressants and then he's on a prostaglandin, you better convert that into timolol, pilocarpine, and maybe 2 aquasuppressants with timolol, and then use pilocarpine, see how the angles open up. Then you could do a PI, because it was done in a all of a sudden way, and then he got it done in one eye. So
He's not allowing it to be done in the other eye.
other eye, yeah. So
Walking around with it.
so if you were to use pilocarpine, you would have sort of, if it had worked, gained his confidence, and then you could sometimes, if you have prostaglandin before PI, this can happen. If he's on something like bimetapros or travoprost, this can happen, because steroid they would have stopped in 5-10 days time. They would have stopped. They would not be tapering it for such a long time. Yeah, because that's why we don't use so much of steroids in our MIGs also. We use only 10 days.
Thank you. Anything else? Correct. So thank you all. Any questions? I don't. Thank you all for for attending this session. And before we close the session, I invite Dr. Manju Pillai to receive a memento on behalf of KSOS. I think Dr. Ronnie and Dr. Ganesh have already received in previous sessions. So I invite Dr. Shweta to hand over the memento.
Just a second.